So every surgery we consider on a patient, we like to try to give some percentages on how we think the patient will do. And we base that on the medical literature or the data. Okay. So, for instance, if we're looking at a patient with a small rotator cuff tear, we know that they're probably going to do well. The rotator cuff will probably heal if they end up having surgery. We know that things we have to watch out are, for instance, stiffness, and we'll have to work through that with the patient and help them through that transition period from after surgery, when most people are stiff after surgery. Almost everyone's stiff to a certain degree after surgery, and some people need a little more help working through that stiffness so that they don't develop what's called a frozen shoulder. So that's one example, is a small rotator cuff tear. We expect a really good result from that. We also have to factor in factors such as, are they a smoker? Is the patient a diabetic? These things hurt the healing process, and we have to be more aware of potential complications or potential for not as good of an outcome as we'd like. On the other end of the spectrum, there are massive rotator cuff tears. So we have small tears, medium tears, large tears, and then there are massive tears, which are basically either barely repairable or not repairable tears. We know that if there is a massive tear with retraction, meaning the tendon pulled back, we know that trying to fix that rotator cuff is likely to end up in a re-tear of the rotator cuff. Sometimes this is still the best option for the patient, but once we have that conversation with the patient and we put a percentage of success on the various options we are providing them, they may choose a different route than the repair, because the repair, let's say, has an 80% failure rate. In that situation, we will give them other options, such as a shoulder replacement may have an 80% success rate. So the patient may want to choose that route. And then there's a very new procedure we call it the balloon, or it's also called the in-space balloon implant. And this can be done through the scope. And this, we've done about 5 of these procedures. It's been around in Europe for 10 years. It's only been around in America, or FDA approved in America, for a couple of months. But so far, the results are very good. And so we may tell the patient about that option, and they may choose that option based on the percentages of success that we give the patient. So we let patients choose their procedure or not procedure. If they want non-operative treatment, they can choose that as well. We like to just give them the options and give them the pluses and minuses, or the pros and cons of each option.